Okay. Hello guys, how are you? How are you all doing? Hope the exam was good. Okay. So we'll start with the questions of anesthesia. Starting with the first question. A 40-year-old female is posted for parotid surgery. She was given general anesthesia. After 10 minutes of surgery, there is a rise in EtCO2. Temperature was 104 and heart rate is 150 beats per minute. The BP is 180 over 110. What is your likely diagnosis? Come on guys, they have given all things related to anesthesia and the surgery. So in the surgery, inside the surgery, the patient is having these all complaints. So first of all guys, remember what happened over here is, after the surgery was started, some anesthetic agent was given and then the patient developed a sudden rise in EtCO2. Sudden rise in EtCO2 or rise in EtCO2, it is the first sign that the patient has developed malignant hyperthermia. This usually occurs before developing a high temperature also. Then the patient developed a high temperature and then the BP was increased and the tachycardia was seen and all. Okay, so what's your likely diagnosis over here? So as I told you, it is malignant hyperthermia, but why it is not heat stroke, guys? Why? Because if it was heat stroke, there should be something related, there should be something given that patient was exposed to sunlight or patient was exposed to heat and all. There is no exposure given, no heat exposure given. So it could not be heat stroke. It cannot be heat cramps or heat pyrexia. Remember guys, in heat stroke or heat pyrexia, again in heat cramps, remember what will the patient have? Patient will be having cramps, patient will be having, okay, patient will be having dehydration. Apart from that, patient will be having normal to elevated, like in mildly elevated temperature. But temperature was 104. And more importantly, patient during surgery develops a high temperature with high EtCO2. That clinches your diagnosis that it's a case of malignant hyperthermia. In case of heat cramps and heat hyperpyrexia, you won't see any rise in carbon dioxide. There is no hypercarbia. You will see hypercarbia only when there is malignant hyperthermia, which is commonly seen during anesthesia. And why it is commonly seen during anesthesia, I told you during the classes also guys. Many of the MCQs I have stated during the LRR session. I gave you this MCQ during anesthesia with sevoflurane. This is the LRR MCQ. A patient develops rapid rise in EtCO2, tachycardia, muscle rigidity. What's the immediate next step? Basically, the diagnosis over here was the patient was developing malignant hyperthermia. The immediate next step, whenever you see a patient develops malignant hyperthermia, what's the next step, guys? The next step would be you stop the triggering factors. And then you can go for the drug of choice. What is the drug of choice? Remember, after stopping triggering factors, you give 100% of oxygen. Triggering factors means usually halothane, sevoflurane. You cut down those triggering factors and you give 100% oxygen, and then you go for the drug of choice, which is IV dantrolene sodium. So again, it was from the important topic, okay, of malignant hyperthermia. Right, we have discussed what is a gene responsible, RYR1 gene responsible, autosomal dominant, usually patient develops masseter, spasm and all. Okay. Next, again, halothane causes a fall in blood pressure. Guys, this were the MCQs given by active recall, given by the students. Okay, so sometimes they might be very much similar, sometimes there is some similarity of 80 to 90%. So next, halothane causes fall in the blood pressure. Yes, halothane, obviously it causes fall in the blood pressure. That's why I told you, whenever we are discussing halothane, I told you 4 hits of halothane. You have to remember, halothane causes hyperthermia. First hitch of halothane, I have told you during the class also, causes hyperthermia. Second, heart disease, it is contraindicated. Third H, hepatitis. Fourth, halothane has 3 maximums. I told you why in heart disease it is contraindicated. Why? Because it causes hypotension and bradycardia. Apart from halothane, propofol also causes hypo and bradycardia. So anyways guys, what we were discussing over here is halothane causes hypotension. A drop of blood pressure of 20 to 30 mm of Hg is common. Okay, yes, a 20% drop of blood pressure from the mean arterial pressure or the systolic blood pressure, it will occur. Take a 20%. It is no different, no value, exact value given. But 20 to 30 mm, okay, yes, you will see after giving halothane. Why? Because guys, basically you need to remember, whenever you give halothane, it decreases the myocardial contractility. And once the myocardial contractility decreases, what happens to the stroke volume? It decreases. What happens to the cardiac output? It decreases. And what happens to the BP? The blood pressure also decreases. And apart from that, halothane will blunt the baroreceptor reflex. Halothane will blunt the baroreceptor reflex or baroreceptor reflex. Normally, guys, remember what happens whenever we develop hypotension, our baroreceptor reflex will get activated, which in turn causes tachycardia, reflex tachycardia. But with halothane, what you will see, there is hypo, and due to blunting of this baroreceptor reflex, you will see bradycardia. Not only halothane, propofol also causes the same thing. Okay, so this is the normal response. This is the response that you see with halothane. So fall in BP starts early and it is parallel to the depth of anesthesia. The fall in BP is always parallel to the depth of anesthesia. The moment I increase halothane, not only in case of halothane, whatever inhalational agent I am using, if I am increasing the MAC value of inhalational agent, basically I am deepening the plane of anesthesia, I will see more hypotension. So that is also right. Okay? It reduces means basically BP reduces with deepening of anesthesia. Again, this is a repeated one, guys. Okay? Some of the students, they told some option was given instead of this third option. Some option was given like halothane reduces the cardiac output. Yeah, that is also right. Halothane reduces the cardiac output. Okay? But the fourth one, the baroreceptor mechanism is activated with the fall in blood pressure. Halothane does not activate the mechanism of baroreceptor reflex. It will blunt baroreceptor reflex. Hence, you will see hypotension and bradycardia with halothane. Okay, so this again was an important topic that we have already discussed in the LRR, the 4 heads of halothane I have told you. Okay, guys, remember it could not be a direct one, but still you can remember hypo and brady was seen with halothane. So how brady will occur if baroreceptor reflex is stimulated? Okay, next. What is the order of structures pierced during lumbar puncture? Lumbar puncture is basically lumbar puncture can be done for spinal anesthesia. Lumbar puncture can be done for any diagnostic procedure. Take a CSF analysis for ruling out the causes of meningitis. So anyways, guys, lumbar puncture or spinal is almost same. Okay? In spinal, you are giving the drug inside the CSF. In lumbar puncture, you are basically draining out some CSF due to any cause. But the order of layers will be the same over here. So what is the order of layer? There was ligamentum flavum given, supraspinous ligament, interspinous ligament, dura mater, subarachnoid, arachnoid. Guys, remember, anyone ask you what is the order of layers which are pierced in spinal anesthesia, your answer should be, some say spinal instigates lethargy during anesthesia. Some say spinal instigates lethargy during anesthesia. So what are the order of layers which are pierced in spinal, guys? Just look over here. The first would be the skin. After skin, what is the next layer? The subcutaneous tissue. Next, supraspinous ligament. Next, interspinous ligament. Next, after interspinous ligament, it is ligamentum flavum. Once you puncture the ligamentum flavum, which is the toughest and the hardest ligament, guys. Okay? Once you puncture the ligamentum flavum, then there will be one more structure pierced, that is called as dura. Once your needle punctures the dura, there will be a thin layer called as arachnoid, and once you puncture the arachnoid, you will be in the subarachnoid space that has a CSF. That is the order of layer. Now don't get confused. Sir, some things were added like basically over here. What could be the order over here, guys? Skin, subcutaneous tissue, supraspinous ligament over here, supraspinous ligament. Next, interspinous ligament. Next, ligamentum flavum, and after ligamentum flavum, it would be the dura, and after dura, it would be basically the arachnoid. Now what is being added over here? Now you will be confused. Sir, dura matter was given. Sir, subdural space was given. This one, like subdural space was given, and someone told me epidural space was also given. Epidural space. So if epidural space was given, okay, and in the option if subdural space was also given, then what will be the order? Guys, remember one thing. Epidural space is not a structure that is present. Basically, it is a space between ligamentum flavum and the dura mater. So it will be placed over here. Epidural space. So that will be the order. After ligamentum flavum, epidural space. That is known only. That's a known fact. Epidural space is the space between ligamentum flavum and dura. Okay? And if at all subdural space was given, then what we need to do is, subdura means what? Beneath the dura, there will be subdural space, and then there will be arachnoid. The last layer to be punctured is arachnoid. Once you puncture the arachnoid, then you will be the subarachnoid space that has the CSF. So that will be the order, guys. Okay, supraspinous, interspinous, ligamentum flavum, epidural space. Fifth is dura, sixth is subdural space, seventh is arachnoid. Is this thing clear? So hopefully, guys, these three questions were easy for you. Okay, we have discussed all these things. That these were the important things. Usually, the question came from the important topics. Even though the lining and the framing of the question was not direct, but so is INI-CET. INI-CET, they won't be asking the direct questions. You have to get your concepts clear with each drug, with each technique of anesthesia and all. Okay, hopefully, guys, your exam was good. So now don't worry. I hope to see you on the other side. All the very best. Okay, thank you.